Okay, so in that case, we'll get started. Good afternoon, everyone, and welcome to CANVax's Webinar Series. Between the fall 2019 and winter 2019, we are hosting a series of webinars to explore current and emerging topics in immunization to support and inform the work of public health professionals like you to improve vaccine acceptance and uptake. To learn more about our upcoming webinars and register, please visit the link you see on the screen, canvax.ca/canvax-webinar-series. Before we begin, we want to acknowledge that CPHA's office is located on the original unceded territory of the Algonquin and Anishinaabe people. They have been the guardians of this land for millennia, and CPHA is grateful for the example their stewardship provides. Today's webinar, Living Better Longer, the Importance of Influenza Vaccine, is brought to you by the Canadian Public Health Association through the Project CANVax and its partners, Immunize Canada, the IWK Health Centre, and the Institut National de Santé Publique de Québec. I'm Riten Xu, Project Officer on the CANVax project with CPHA, and I'll be your moderator for today. A quick note that the webinar is being recorded and will be made available on canvax.ca, our website, and on CPHA's YouTube channel shortly after the conclusion of this presentation. Please also note that upon the end of the presentation, you'll be invited to complete a 5-minute survey. The feedback you provide will be used to assess your satisfaction and identify areas for improvement of the delivery of these webinar series. So please do take the time to provide your feedback. Further, if you haven't already registered or subscribed to our newsletter, you can visit canvax.ca to do so to get access to the latest resources and tools. If you encounter any technical difficulty, please use the Q&A feature at the bottom of your screen and send us a message. If you would like to suggest topics or speakers for our upcoming webinars, you may contact Antonella Pucci at apucci@cpha.ca. We strongly encourage attendee participation and look forward to hearing your thoughts and questions. So please feel free to submit your questions at any point during the presentation by using the Q&A feature. Only you can see your questions, and you can also submit them anonymously. Once a question has been answered, you'll see the question in your Q&A window, at which point it will be answered live. All questions for the speakers will be answered at the end of the presentation. So with that, I would like to introduce our speaker for today's webinar. Our speaker today is Dr. Shelly McNeil. Dr. McNeil is a clinician scientist at the Canadian Centre for Vaccinology, Dalhousie University. Her research focuses on investigation of vaccines and vaccine-preventable diseases in adolescents and adults, including pregnant women and immunocompromised populations. She conducts phase 1 to 4 vaccine clinical trials, as well as studies the epidemiology of infectious diseases in adults. She is the principal investigator of the PCIRN Series Outcome Surveillance Network, a network of 10 academic acute care adult hospitals established to evaluate the epidemiology and healthcare utilization associated with vaccine-preventable diseases leading to hospitalization in adults, and to provide ongoing estimates of vaccine effectiveness. So with that, I would like to turn it over to our speaker, Dr. Shelly McNeil.
Thanks very much.
Okay. Dr. Shelly, you can go ahead and share your presentation.
All right. Thanks very much for that introduction. Pleasure to be here today. Thank you for inviting me. As was said in the introduction, I'm going to chat a little bit about data supporting the use of influenza vaccines in older adults, with a special focus on the special things about influenza in older adults. As was mentioned, I'm a vaccine researcher. I'm an adult infectious disease specialist, but also do vaccine research a good chunk of my time. So I do have financial relationships of one sort or another with all of the vaccine manufacturers. I have in the past been a member of NACI, as you see there, and I'm the current chair of Immunize Canada. So today I wanted to review the burden of influenza as it applies specifically to older Canadian adults. To discuss the importance of understanding the relationship between frailty and influenza as a means to better support the need for influenza vaccine coverage in older adults. I'll talk about the Canadian data supporting the effectiveness of both standard dose TIV and QIV, for that matter, for the prevention of serious outcomes in older adults, as well as the data supporting the use of high dose and other enhanced vaccines for older adults. So impact of influenza in older adults, we largely think about outcomes of influenza and burden of influenza often in terms of the number of cases of influenza we're able to prevent, the number of hospitalizations, the number of physician visits. But arguably in older adults, influenza has much greater implications than just that. And unless we think about those broader implications, we underestimate the potential benefits that influenza vaccine may offer in this population. So as you know, adults over the age of 65 represent only about 15% of the Canadian population, but largely they account for the majority of the morbidity associated with influenza in Canada. In this particular season, 16-17, about 67% of hospitalizations due to influenza and 88% of influenza-related deaths. In the Serious Outcome Surveillance Network, where we do real-time surveillance for influenza over the last 10 years or so in Canadian hospitals, the rates of hospitalization due to influenza in older adults, they make up over 70%, and in fact about 50% of hospitalizations are in people over the age of 75, and they make up over 90% of influenza deaths recorded in the SOS network. It's important to note that influenza also variably affects people depending on their underlying health status. So I'm going to talk specifically about frailty in a moment, but certainly influenza we know causes more deaths in people who have chronic conditions. We know that amongst people over the age of 65, the risk of influenza attributable mortality is about 5 times higher if someone has underlying heart disease, and about 12 times higher if people have chronic lung disease. And of course, these often go together in younger, but also largely in older adults. And if a patient has both chronic heart and lung disease, the risk of influenza-associated mortality is about 20% higher than if they had neither. Of course, in addition to the respiratory, direct respiratory complications or illnesses associated with influenza, we also know that influenza is related to the exacerbation of underlying chronic medical conditions such as asthma, COPD, other pulmonary conditions, but also renal disorders and diabetes. And importantly, there's emerging data supporting the fact that influenza can serve as a trigger for cardiovascular and ischemic cardiovascular and stroke related illnesses. Just a little bit about that. That data has been emerging for really, many decades, and you've probably seen this epidemiologic curve before, where early ecologic studies were designed to try to investigate cause-specific mortality during influenza epidemics. And it was found that that influenza accounts for about 15 to 30% of excess in expected cardiovascular mortality during the influenza pandemics and epidemics in 1819 and 1920. Since then, though, more contemporary data has clearly shown a relationship in the early period after influenza with an increased risk of myocardial infarction and stroke. So here you can see that in the period, usually up to sort of 3 days and even out to 5 to 7 days, the risk of myocardial infarction is dramatically increased in older adults, as is the risk of stroke. And there's good biologic plausibility to that theory because we know that influenza has direct inflammatory effects on the myocardium and the vasculature. So influenza-associated myocarditis, which is characterized by infiltration of inflammatory cells, as well as cardiac necrosis, can be seen in up to 10% of people infected with influenza. And most cases are mild and resolve spontaneously, but that inflammatory cascade in the vasculature may be what accounts for the increased risk of cardiovascular outcomes that are seen in many studies. Of course, if that relationship is real and influenza is in fact the precipitant for this increased risk of stroke and ischemic heart disease, then one should be able to see an impact of influenza vaccine on those outcomes. And that's been a topic of much interest, of course, over the last couple of decades. So this was a large randomized controlled trial done by Jay Udell, a cardiologist, in Ontario, published in JAMA in 2013. And you can see that if you took a composite endpoint of cardiovascular death, myocardial infarction, stroke, heart failure, unstable angina, or the urgent need for coronary revascularization, there was a benefit of influenza vaccine observed over those who, in the year after influenza vaccine was received, with an absolute risk of 2.93% in people who had influenza vaccine in the year following versus 4.67% in those not vaccinated, giving a relative risk of this composite cardiovascular endpoint of 0.64, an absolute risk difference of 1.74% with a number needed to vaccinate to prevent one of these outcomes, or this composite outcome, of 58. As one might imagine, that is the effect is most dominant in those with a recent coronary syndrome. So those at the very highest risk of having a recurrent cardiac event are benefit the most, with a relative risk of 0.45 amongst people with a recent acute coronary syndrome in the year following who are vaccinated with influenza. So here, an absolute risk difference of 12.9% with a number needed to treat of only 8. So recognizing the increasing risk of cardiovascular events in older people and its association with precipitation of myocardial infarction, less so data available with stroke, but similar relationship, that the importance of influenza vaccine should be highlighted for that reason as well, not only to be able to prevent influenza illness itself. The other thing we've been looking at in the SOS network is to try to get a sense of the impact of influenza and influenza vaccination on functional outcomes in older Canadians. So the geriatricians use a term called catastrophic disability, and they define that as a loss of independence in 3 or more activities of daily living. So you can imagine if you're an older adult living in the community, experiencing a loss of independence in 3 or more activities of daily living is not only a statistically important outcome, but also clearly an important outcome for individual health. Interestingly, about 72% of people who experience catastrophic disability experience it at or after a hospitalization. And when you look at the leading causes of catastrophic disability, from several different studies, the leading causes are stroke, heart failure, pneumonia and influenza, ischemic heart disease, cancer, and hip fracture. And if you believe the lead-in, what I told you in the lead-in, you can see that many of these things may be, at least in some measure, preventable with influenza vaccine. So stroke, CHF, pneumonia, influenza, ischemic heart disease, all have been clearly shown to be associated with influenza. And those of you who take care of older adult patients will know that these are common things that we feel are a downstream effect often of having had influenza. So the end result of that, of course, is that healthy or tenuously healthy older adults living in the community who suffer a hospitalization will frequently not return to their functional baseline. And that hospitalization can be of any cause, but again, largely the causes of hospitalization that lead to catastrophic disability may be preventable through vaccination, not only through influenza vaccination, but also through other immunizations such as pneumococcal vaccine. In our studies in the Serious Outcome Surveillance Network, we've focused a great deal on looking at functional outcomes of influenza-related hospitalization in older adults. And we've observed over the last, as I say, about 10 years or so, that overall 15% of our 65-year-old plus population hospitalized with a diagnosis of influenza do not return to their baseline and meet the definition for catastrophic disability. So if you think about that, 15 out of every 100 adults who are admitted, older adults who are admitted with influenza, will experience loss of independence in 3 or more activities of daily living. That is clearly a very important public health benefit of influenza, which we should be trying to measure. So we don't only want to prevent lab-confirmed influenza, though that's important, but what we're really trying to prevent is the hospitalizations due to influenza, which in themselves are associated with significant health service utilization and cost to the healthcare system, in a system that, as we know, has very little surge capacity to accommodate that increased risk of hospitalization with influenza. But importantly, we also want to try to prevent this 15% of older adults who subsequently go on to have chronic disability related to their hospitalization. This, you could imagine, this increase in this loss of independence that we observe is difficult. It's difficult to quantify its impact on the health system and on health service utilization, but clearly a large proportion of that results in increased needs for care in the home, increased needs for transfer to long-term care facilities, and other support. So when one thinks about the cost effectiveness, probably this audience, I don't have to argue too much about cost effectiveness of influenza vaccine, but certainly when we look at cost effectiveness studies that examine the impact of influenza vaccine, we're largely underestimating because we're not accounting for this downstream functional decline that adults will experience and the costs associated with caring for those adults in the rest of their life. This slide is really just to make the point that all of this information really represents the tip of the iceberg. We know that any ILI criteria, influenza-like illness criteria that we use to try to identify patients with influenza perform poorly in terms of sensitivity and specificity, and in hospitalized patients, this is data that Melissa Andrew has been working on in the SOS, really does show that the sensitivity of ILI case definitions, even if you loosen up the fever criteria, only will predict influenza in about 40 to 60% of hospitalized older adults. So we know that, and we know that those definitions are not intended to be used in individual patient-level decision-making, but it's very clear in the SOS network that they are, in fact, used by clinicians to decide who to test, who to isolate, who to treat for influenza. So if people are thinking about ILI in their mind, if they're thinking about ILI as a means to try to distinguish which older adults are coming into hospital with an acute respiratory illness may have influenza, and using that definition in their head, which they may not know to articulate as ILI, but have this picture of what influenza should look like, they will not test and they will not identify influenza. So the number of hospitalizations that are reported due to influenza are grossly underestimated, and we've seen a dramatic increase over time in the SOS network of clinician-driven testing for influenza as we've been able to show clinicians that, for example, 30% of hospitalizations in Canada due to COPD exacerbations during the influenza season are attributable to influenza if you actually test for influenza, whereas before we did not know what burden influenza was playing in that. So older adults do present atypically. They often present with exacerbation of underlying medical conditions. Interestingly, even in those people in the SOS network who have a lab-confirmed diagnosis of influenza during their hospitalization, it is almost never identified in the discharge summary as the cause for hospitalization. So I think even though we're testing people now, we still largely have clinicians who are underestimating the attributable burden of influenza in hospitalized patients, and they'll still write, admitted with an acute exacerbation of COPD, a whole bunch of information about that diagnosis, and then somewhere incidentally in the rest of it, when they list what positive lab tests they had, for example, in a discharge summary, they may comment that the influenza PCR test was positive, as opposed to labeling the admission related to influenza. So this I say to relate not only to sort of clinical care, but also to caution in the use of administrative data for looking at the burden of influenza, because we know that at least in adults, testing is suboptimal. Coding is definitely often not done, because even if a diagnosis of influenza was made during the hospital stay, it may not end up getting coded as influenza and rather coded as an exacerbation of heart failure, asthma, COPD, or some other underlying condition. So really we're looking at the tip of the iceberg, and the point of the Serious Outcome Surveillance Network really is to try to better define that by systematically testing people who are admitted to hospital with acute respiratory illness. Of course, the problem in older adults is this immunologic phenomenon of immunosenescence, so aging of the immune system, both the antibody-mediated immunity as well as cell-mediated immunity with age, which occurs normally with age, is largely what's contributing to the increased incidence of serious outcomes of influenza that we've been talking about, but also, of course, results in decreased response to vaccination. And I've been in the business, obviously, of reporting interim and final season, year-on-year vaccine effectiveness, recognizing that there's lots of things that play into that, and effectiveness will vary considerably year to year and based on age group and other comorbidities. But what is largely true across all studies is that older adults tend to have lower response to vaccination, translating into lower immunologic response to vaccination, translating into lower effectiveness against disease prevention, irregardless of the year or the study that you look at. That being said, it's worse in some circumstances than in others. So this is the Serious Outcome Surveillance Network, a network of the Canadian Immunization Research Network, formerly known as PCERN. This is a little bit out of date because this was really just to make the point that the number of sites included in the network varies year on year depending on how much funding we have. Right now, this network has become a surveillance network for the Public Health Agency of Canada on contract with Public Works Canada, and then presently operates in 8 centers, mostly centered down here in the east. But in this coming fall, we'll be adding another center in British Columbia. If you're interested in details about the network, this vaccine publication would give sort of a broad look at it. As was mentioned, the purpose of this network is to better define influenza-related burden of disease causing serious illness in adults of all ages. So we do active surveillance for influenza amongst all adults admitted to these participating hospitals each season, trying as best we can to ensure that all people with acute respiratory illness get tested for influenza. And then using a test-negative case control design, we look at the ability of influenza vaccine to prevent that hospitalization. So these are adjusted VE estimates for influenza by type and subtype. As I mentioned, many of us are in the business of showing you annual rates of vaccine effectiveness, as well as effectiveness by strain and by age group and the like. But one could argue, and I think we have successfully argued over the years, that what we really care about is the average impact of influenza vaccine on serious outcomes. And that is to say, yes, we may have years where the vaccine works less well, some years where it works better, but on average, what can we tell Canadian older adults that the chances are that influenza vaccine will prevent hospitalization or provide them with personal benefit? So this is only 3 years of pooled data, but we have pooled other seasons. It still sits around this number. But on average, we've been able to show with this test-negative case control design in hospitalized Canadian adults that the current publicly funded immunization program has an effectiveness of about 42% in the prevention of hospitalization in adults in Canada. This is a little bit lower in people over the age of 65, so around 40% of hospitalizations in people over the age of 65, and a little bit higher, as you might expect, in people under the age of 65. It does vary based on the strain, and we know that from our studies and from other studies, with higher effectiveness in the prevention of H1N1 influenza, lower in H3N2, particularly lower in people over the age of 65 who are infected with H3N2. But importantly, in all but one season in the last 10 years, the Serious Outcome Surveillance Network has demonstrated statistically and arguably clinically important protection against H3N2 related hospitalization in older adults. We tend to have less B virus admitted in the network because older patients are less frequently admitted to hospital with influenza B, so the sample sizes are a bit wide and the confidence intervals are a bit wide. But again, we have been able to demonstrate effectiveness in the prevention of hospitalization due to influenza B as well. Importantly, when we're thinking about sort of public health benefit of these programs, what the vaccine effectiveness estimates that you see will vary also on the outcome that's being looked at. So you will see published vaccine effectiveness estimates for the prevention of medically attended influenza in the community, for example, and our estimates for influenza-associated hospitalization. These are this black is the data I just showed you. But we can also look at the impact of the vaccine on other outcomes. And as the severity of the outcome you look at increases, the vaccine tends to perform even better. So in this case, we looked at prevention of ICU, or the requirement for mechanical ventilation in Canadian adults over these 3 influenza seasons, which, as you saw from the first slide, did reflect circulation of all of the strains of influenza over those 3 years. But importantly, we were able to see an overall prevention of influenza-associated death of 74.5% in people over the age of 65 during those 3 seasons. So an important clinical benefit in the prevention of both hospitalization, but also the complications of that can occur during hospitalization, the most severe outcomes, including ICU, ventilation, and death, suggesting that even in people who get influenza, disease is attenuated to some degree in patients who are vaccinated. This is the most recent season of effectiveness data I have available to show you. This is the 2018-19 season. Again, it was a season largely an influenza A season. Overall in the SOS network, about 97% of hospitalizations in 2018-19 were due to influenza A. About 68% of those were H1N1 and less due to H3N2. Lots of them, we're not able to type everything, so we don't know, but you can assume that a lot of this data relates to H1N1. Here are the sort of end of season estimates. So again, similar to what we've seen in the past, about 43% overall protection against influenza-associated hospitalization across all age groups. Again, higher in the younger adults, so about 50% efficacy for the prevention of hospitalization in people under the age of 65 and about 31% over the age of 65, so fairly consistent. But importantly, we have a large number of patients over the age of 75, as I mentioned, depends on the season, but anywhere upwards of 40 to 60% of people are over the age of 75. And you can see that the vaccine continued to provide protection against hospitalization even in the elderly adults. Differences again in influenza A versus influenza B, and this problem of influenza A, H3N2, which is an ongoing challenge for vaccination in the elderly, because when we see influenza A, H3N2, we can typically predict that vaccine effectiveness will be lower. And that's, of course, a challenge because we often see seasons characterized by H3N2 as the dominant strain. So this was up to 16-17, where 5 of the last 8 seasons in that period of time were related to H3N2. So much of the focus around improved vaccine delivery for vaccine development for older adults focuses on overcoming immunosenescence, mainly with the goal to improving effectiveness in the prevention of H3N2 related complications, because as I showed you earlier, the the protection from currently available vaccines against H1N1 tends to be quite high, even in the elderly. It's really a problem largely of preventing H3N2. So, you know, the use of influenza vaccines in older adults is sort of a glass half full, glass half empty kind of problem. You hear in the media of many times, especially when we're publishing these estimates, you know, a VE estimate, for example, of 42%, people will say, well, that's very low. Why are we even doing it? Are we wasting our money, et cetera, et cetera, et cetera? And I would argue, and I think all of you would agree, that if we can prevent 40% of hospitalizations in older adults, recognizing what we know to be the impact of those on not only exacerbation of underlying medical conditions, but also on functional outcomes and frailty, we are doing a tremendous service to the public by doing that, and not doing that would be very short-sighted. And if that's not convincing enough, then we could also argue that we're preventing not only those hospitalizations, but also attenuating disease such that we're preventing influenza death, influenza-associated death even more often. So without question, whatever I'm going to say about any new vaccines that are available, there is no question that in my mind, and I suspect in your minds, influenza vaccine for older adults is a key priority in the strategy to reduce influenza-related complications in Canada. The other thing to note, though, is that when we do these vaccine effectiveness studies, and that's true of our studies as well as pretty much any study you will see in the literature about vaccine effectiveness in the community, you will note that we typically lump people under the age of 65 and people over the age of 65 together. But all of us know that all 65-plus-year-olds are not the same. All 75-year-olds are not the same. There are the 75-year-olds who are out golfing and working and all of those things and have limited comorbidities, and then there are the 75-year-olds who are frail and have multiple comorbidities, are in long-term care facilities, et cetera. So we do a disservice to vaccine effectiveness estimates when we lump the over 65 population together. And Melissa Andrew, my colleague, who's a geriatrician, you may have come across, who does a lot of work with influenza in older adults, has been trying to look at the relative effectiveness of influenza vaccines stratified by the level of frailty of patients, and we do use standardized measures of frailty I don't have time to get into today. But what we find from those studies is that it's really the most frail group. So this is largely the group that's in nursing homes, in fact, that is driving the estimates down for influenza vaccine in the over 65 population. And if you look at the population that are well in the community, even up to the point where they end up in a long-term care facility, the estimates for vaccine effectiveness are actually quite high. So we're doing a considerable disservice by lumping them together because we know that most adults in the community are not frail. The prevalence of frailty in the community is about 24% in Canada. So 75% of adults are not frail, and therefore we would expect vaccine effectiveness estimates in that population to be more similar to younger adults. And when I showed you the stratification by age in that earlier slide, you could see that, in fact, even in the oldest groups, vaccine effectiveness can be high if we stratify by frailty. So recognizing that vaccine effectiveness is poorest against influenza H3N2 and poorest again in those who are frail or who have multiple comorbidities, there have been efforts, of course, to create better vaccines that are designed, as I mentioned, to overcome immunosenescence, to improve immune responses to vaccine, and hopefully to translate into better protection. There are two that we use in Canada. The first is adjuvanted trivalent influenza vaccine. So this is standard dose TIV adjuvanted with an oil and water adjuvant called MF59. There is a adjuvanted QIV available in children, but I don't think yet available in adults, but coming. And this vaccine has been around for a long time. It's licensed in over 20 countries. It's been largely used in Europe prior to sort of recent past where it's been used in North America. And it does include this MF59 adjuvant, which has been shown to enhance antigen persistence at the injection site, therefore sort of increasing exposure of the immune system and immune-activated cells to the antigen. Does improve immune responses in older adults, and also there's been some evidence that it improves cross-protection against heterologous influenza strains, particularly H3N2 drifted strains, in both children and in older adults. There have been lots of studies trying to look at the effectiveness of adjuvanted influenza vaccine, all of which one could argue had significant methodologic flaws, and they're well reviewed in the NACI influenza statements over the last few years. But most of those studies, which are observational trials, non-randomized observational trials, including us trying to look at this question in the SOS network, have been able to show a relative effectiveness of about 25% for adjuvanted vaccine versus non-adjuvanted vaccine. But again, with considerable concern in some of those studies, probably even mine, about methodology. Additionally, there's been other studies, case-controlled studies, looking at adjuvanted vaccine absolute effectiveness, which didn't show any significant difference between normal standard trivalent vaccine versus Fluad, and others that showed sort of widely overlapping confidence intervals. So the jury is largely out on the relative effectiveness of, really the jury's out on the effectiveness of adjuvanted influenza vaccine overall in the prevention of serious outcomes, but certainly there's no comparative studies, randomized controlled studies comparing it with high-dose influenza vaccine, which I'll talk about next. So high-dose influenza vaccine is a trivalent inactivated influenza vaccine, which uses 4 times the standard dose of regular influenza vaccines of each antigen. It's an inactivated split virus vaccine, doesn't contain an adjuvant, and has been authorized for use in Canada since September 2015 and available in Canada since 2016-17 season. And it's been a bit of a moving target, what the use of this vaccine in publicly funded programs has been, and it has continued to evolve. So several provinces, I think I took the slide out because I didn't know for sure that it was accurate, but several provinces across the country do use this vaccine in long-term care facilities, and Ontario, as you likely know, does use this vaccine as part of its publicly funded program for all adults over the age of 65. In Nova Scotia, we just started using it last year, but it's restricted to use in patients in people in long-term care facilities. So this is a vaccine that was authorized largely on the basis of these two large randomized placebo-controlled trial published in the New England Journal in 2014, which randomized about 16,000 patients to high-dose influenza vaccine and 16,000 to standard dose vaccine made by the same company, and then looked at various endpoints. So the primary endpoint was lab-confirmed influenza, not requiring hospitalization, but lab-confirmed influenza, where high-dose vaccine was shown to have a relative efficacy of 24.2%. And interestingly, that efficacy benefit extended into the extremes of age, so relative efficacy of 32% in people over the age of 75. And in fact, that's what you might expect to see, even more of a difference in between this vaccine and standard dose vaccine as people become older or more frail, and that was also observed. Importantly, though, there's now been a considerable amount of experience with high-dose vaccine in the real world. So there's been, this vaccine has been used has had significant market share in the United States for quite some time. So there's lots of data emerging from the US trying to look at the relative effectiveness of the high-dose vaccine versus standard dose vaccine in US populations. This study was published in Lancet Infectious Disease and again confirmed the relative effectiveness that was observed in the clinical trials, with a relative effectiveness of 22% in the prevention of lab-confirmed ILI, 22% in relative to standard dose vaccine in the prevention of emergency department visits and hospitalization. And again, as one might expect, when standard dose vaccine is really not working in the oldest and most frail in some cases, the difference expands as you look at the extremes of age. This is another one in Medicare recipients over the 11-12 and 12-13, pardon me, and 13-14 season, which again, if you combine the two seasons, showed a relative effectiveness of 15% for influenza-related illness, 18.6% for hospitalization, and influenza pneumonia-related deaths, relative effectiveness of 24%. You can see that there was less of a difference between standard dose vaccine and high dose vaccine in the season that was in which H1N1 influenza circulated. And again, that's because the standard dose vaccine effectiveness tends to be higher against H1N1, but more important differences noted when in a season when H3N2 was circulating, as one would expect. Oops, sorry. I'm going to skip these except to say there's been many other and probably more than I have in these slides, real-world effectiveness trials that have confirmed the relative effectiveness of high-dose influenza vaccine over standard dose vaccine for many clinical outcomes, importantly, though influenza-associated hospitalization. This is a study looking at the comparative effectiveness of high dose versus standard dose on hospitalization long-term care residents. And this is an important study because in many provinces we are using it in this population. So one would want to confirm that it's not only the community dwelling healthier adults where this vaccine is conferring additional protection, but also those who are frail and in long-term care facilities. And you can see that for the prevention of hospitalization, the relative risk was 0.68 in those who received high-dose vaccine versus a standard dose vaccine. They were not able to demonstrate in this study a reduction in in deaths related to influenza or on functional outcomes, although the study wasn't powered to look at that. This study's hot off the press, published just in press now in Vaccine. This was a study using administrative data in the United States that included over 800,000 people vaccinated with high-dose vaccine compared to 34,000 with adjuvanted. So this study is trying to address the question that all of us have been asking about whether, recognizing that we have two available options to potentially improve protection in adults, high-dose vaccine and adjuvanted vaccine, and there's a considerable cost difference between those products, it's important to try to understand whether they offer the same amount of benefit. And I showed you that the data around adjuvanted vaccine is conflicting, but at the same time does tend to show a similar relative effectiveness benefit versus standard dose vaccine, as I've showed you for high dose vaccine, but in much less rigorous methodologic studies. So provinces, I think, have been grappling with the decision about whether they should use high-dose vaccine in this population, recognizing it's associated with considerable expense, or could they use adjuvanted vaccine and get similar benefit and at a lower cost. So I think that's been a popular public health question we've all been trying to answer, and it has been challenging. We are in the SOS network trying to answer that question, recognizing now that we will see considerably more use of high-dose vaccine. In Ontario, we're hoping to achieve sample sizes of hospitalized adults where we may be able to start to answer that question, or at least to see what the relative effectiveness is against standard dose vaccine. Probably we won't see enough adjuvanted vaccine use to be able to comment on that question. But this study was trying to look at the relative effectiveness of high-dose vaccine versus adjuvanted vaccine for the prevention of hospitalization over 2 seasons in the United States. Large numbers of patients, particularly in the high-dose arm, because again, it is the dominant recommended and used vaccine for older adults in the United States. And you can see that the relative effectiveness for the prevention of hospitalization due to respiratory disease was 12% in these 2 seasons. Also showed a relative effectiveness benefit of 7% for the prevention of hospitalization due to a broader cardiorespiratory disease outcome. And this urinary tract infections were used as a control because of the problems I mentioned before around administrative databases and the ability to ensure that things are coded the way they should. So you would not expect, obviously, to see a benefit for the prevention of urinary tract infections, and they didn't see that. So at least in this study, which is fairly large, sort of real-world administrative data, again, there was a benefit of adjuvanted and high-dose vaccine, but there appeared to be higher efficacy conferred or effectiveness conferred by high-dose vaccine than conferred by adjuvanted vaccine in the prevention of important serious outcomes in older adults. So since the last couple of years, NACI has made, one could say, a preferential recommendation for the use of high-dose vaccine in people over the age of 65 years. The statement this year, I was doing this at the last minute, so I apologize if I didn't quote exactly, but essentially even in the 2019-20 season at an individual level, NACI has recommended that when high-dose vaccine is available, it should be used in preference to standard dose vaccine for people 65 years of age and older, recognizing the burden of H3N2 that I showed you and the good evidence of better efficacy compared to standard dose vaccine in this age group. They, on the other hand, concluded that there's insufficient evidence to make comparative recommendations for the use of any other vaccine over standard dose vaccine in this population. From a public health perspective, for publicly funded programs, NACI has continued to recommend that any approved influenza vaccine can be used in older adults in publicly funded programs. But at an individual level, recognizing the data I showed you, have made a preferential recommendation for high-dose vaccine. So I hope we all agree that our job as public health physicians and healthcare providers in general is not to add years to life, but rather to try to improve the quality of life, prevent the progression of frailty. This is sort of the natural progression of frailty. This is a large part of the population of older adults living in the community, sort of on this slope, but functioning fine and doing well in the community. And the goal of vaccination really is to keep people in this ballpark and not lead them down the frailties ladder as they accrue more and more insults with hospitalizations that could have been prevented. We know that exercise and social engagement and other things can improve quality of life and prevent frailty, but importantly, I think we are making the argument that progression of frailty can also be vaccine preventable, mostly with influenza, but also with pneumococcal vaccines. So I think we should be actively recommending vaccine for older adults across all grades of frailty. We should be considering different products and thinking about whether certain patients will benefit from certain products, most specifically thinking about the recommendations for high-dose vaccine in individual adult patients, older adult patients. Important, obviously, to recognize that none of these vaccines are 100% protective in older adults. And those who are frail are least likely to be protected by any of the vaccines available. So it's important that we encourage vaccination amongst all of those people who could transmit influenza to that population. It's important that we encourage clinicians to test and look for influenza and consider influenza, because I didn't talk to you about the value of antivirals, but in hospitalized patients, antiviral medications are recommended and do improve outcomes in hospitalized adults. So we need to be thinking about influenza more, broadening our view of what influenza looks like in older adults, actually looking for it, isolating it, and treating it. And I think it's important that we continue to pursue this idea that we can prevent progression of frailty with vaccination and power our clinical trials, or at least look at this outcome in our clinical trials and consider it in things like cost-effectiveness studies, which will help support the use of these more expensive vaccines, in my view. So I will stop there. I do have some questions popping up here, so I'll try to answer them. So what is the recommended vaccine for those living in long-term care but are 64 years of age or younger? So the high-dose vaccine is recommended, and adjuvanted vaccines are recommended in the 65-year-old age group plus. We have been starting to look at this question of frailty in younger adults because clearly younger adults can also be frail, but the current recommendation is that those receive standard dose quadrivalent or TIV, most provinces using QIV at this stage. We've been told in Nova Scotia that Fluzone high dose will not be available to pharmacies until December. What do you recommend? Oh, sorry, I'll just put that back up. What do you recommend pharmacists do when asked by patients for Fluzone high dose? Should they advise the patient to wait or to receive standard dose vaccine as soon as possible? So this is the most popular question I've been getting in the last week or so. So the person asking the question is correct, and I did talk to the company that Fluzone high dose is going to be delayed for the private market. So it is on schedule apparently for delivery to publicly funded programs, including the long-term care program in Nova Scotia, but will be delayed for private sale. This question is a difficult one to answer. To some extent, it depends on what the season looks like, but looking at Australia's season, it is likely that we'll see an H3N2 dominant season. It's quite possible we'll see an early season. So I would say that the safest thing to do would just be to vaccinate them, because I would hate to see that we don't vaccinate our most vulnerable population and then have flu come into the community while we're waiting for high-dose vaccine. Keeping in mind that, you know, there is a relative efficacy benefit, but there's certainly no efficacy if we don't vaccinate at all. So I would recommend that we just go ahead and vaccinate them. Your next question, which no one's typed yet, but which always follows when I answer that, is can we then give them high-dose vaccine later when it becomes available? And there's no data to support that, no recommendation to support that. So I think, you know, it's a risk-benefit discussion between you and patients and perhaps people like me and not on a webinar. Not sure if people have other questions. Those are the ones I can see so far.
Yeah, I believe there is a one question that's still open on.
Oh, sorry.
That's okay.
Yeah. What's the recommendation for antivirals for those hospitalized with flu? Should all patients with flu? So yes, if you look at the most recent AMI guidelines, the Association of Medical Microbiologists Infectious Disease, AMI, as well as CDC recommendations, antivirals are recommended for all patients admitted to hospital with suspected influenza, so you don't even need to wait for them to have a positive test. If people are coming into hospital with an acute respiratory illness in influenza season, so you know flu is circulating in your community, the recommendation is that those patients be started on an antiviral, tested for influenza, and you can always stop if the test is negative. But the benefit of antivirals is really dependent on the time from onset of illness. So the recommendation is clear that they should get antivirals, but also clear that you shouldn't wait for an influenza test. So if someone comes in and you think they could have flu, which as the point I made earlier, you should be thinking that everyone could have flu if they come in with an acute respiratory hospitalization in the middle of flu season, all of those patients should get an antiviral until you prove that they don't have flu, as opposed to thinking about it the other way around.
Okay, I think that's the end of the question period. Thank you very much, Dr. Shelly, for your presentation. It was very enlightening and definitely adds to the conversation on what to do as we're heading towards the flu season and the deployment of or perhaps delay in certain regions for the flu vaccine. So that brings us to the end of the webinar. Thank you everyone for joining us. And oh, give me one moment. Let me change my screen here. Approach. And There we are. Yes. So thank you again for joining us. Please don't forget to provide your feedback using the survey that will be made available to you upon the end of our webinar. Thank you, everyone, and have a wonderful afternoon.
Thanks, everyone.